Chapter 12: Shock, Sepsis, and Multiple Organ Dysfunction Syndrome. Shock is a clinical syndrome characterized by inadequate tissue perfusion. It's a clinical condition that contributes to shock, including ineffective cardiac function, inadequate blood volume, and conditions that result in inadequate vascular tone. The end result of inadequate tissue perfusion is an imbalance between cellular oxygen supply and demand. Shock impacts all body systems. If not recognized early, the compensatory mechanisms may fail, resulting in organ failure and death. Again, shock is a clinical syndrome characterized by that inadequate tissue perfusion, and this results in cellular, metabolic, and hemodynamic derangements. The impaired tissue perfusion can occur, and there is an imbalance between that cellular oxygen supply and demand. And shock can be that end result from the ineffective cardiac function, inadequate blood volume, or inadequate vascular tone. The cardiovascular system is a closed system composed of the heart as the primary pump, circulating blood volume, and the vascular bed, which is composed of arteries, arterioles, capillaries, venules, and veins. The microcirculatory system is the most critical portion of the circulatory system and is necessary for cellular survival. And functions of the microcirculatory system include delivering the oxygen and nutrients to the cells, as well as removing the metabolic waste products. Shock begins when alterations occur in one of the four essential circulatory components, being blood volume, myocardial contractility, blood flow, or vascular tone or resistance. The body attempts to compensate when one component fails, another attempts to pick up the slack. However, compensatory mechanisms ultimately fail and the underlying problem is not corrected. There are four different classifications of shock: hypovolemic, cardiogenic, obstructive, or distributive, such as in the case of anaphylaxis, neurogenic, or septic. Shock occurs in a continuum. What is most important is that if signs and symptoms are not recognized early, they can quickly progress to the next stage. Stage 1 of shock begins with that initial state of hypoperfusion. There are no obvious clinical signs noted, although if the patient is being hemodynamically monitored, there may be alterations in the cardiac output. During stage 2, or the compensatory stage of shock, symptoms become apparent as hyperventilation occurs. These compensatory mechanisms are activated in an attempt to maintain blood flow to the tissues. Baroreceptors, which are sensitive to changes in pressure, and chemoreceptors, being sensitive to chemical changes, relay messages to the vasomotor center in the medulla to stimulate the autonomic nervous system to help release epinephrine and norepinephrine. Release of these catecholamines leads to an increase in heart rate and contractility for the purpose of improving cardiac output. Endocrine compensation also occurs as a decrease in blood pressure results in messaging to the hypothalamus, which stimulates the posterior pituitary gland to release ACTH. This releases other hormones, like glucocorticoids, that act to increase blood sugar, while mineralocorticoids act on the renal tubules to increase the reabsorption of sodium and water, increasing intravascular fluid volume and pressure. If stage 2 is not recognized and properly reversed, shock progresses to stage 3. This continued vasoconstriction shunts blood to the vital organs, but robs the extremities of perfusion. Prolonged vasoconstriction results in decreased blood flow to the cells, ultimately leading to anaerobic metabolism and increased lactic acid production. Fluid shifts occur as the capillary hydrostatic pressure increases, and the fluid shift further decreasing vascular volume. This results in capillary sludging, which further alters perfusion. Again, that prolonged vasoconstriction results in decreased blood flow to the cells, ultimately leading to that anaerobic metabolism and increased lactic acid productions. We want to be very cognizant of assessing for any intravascular fluid shifts or decreased coronary perfusion especially. In the final stage of shock, or refractory stage of shock, this results from prolonged inadequate tissue perfusion. The stage of shock is unresponsive to therapy, and ultimately organs begin to fail, increasing the patient's mortality rate. Another syndrome that can lead to multiple organ dysfunction and failure is systemic inflammatory response syndrome, or SIRS. SIRS is a widespread inflammatory response associated with a variety of disorders such as ARDS, infection, trauma, shock, pancreatitis, or even ischemia. Theirs is a systemic response associated with the release of inflammatory mediators. The release of these mediators leads to changes within the vessel wall permeability, which further leads to fluid shifting out of the vascular space, depleting intravascular volume and resulting in a relative hypovolemia. Additional mediators further lead to widespread breakdown of clots and vasodilators. Assessment of a patient at risk for shock focuses on history, clinical presentation, and laboratory studies. The assessment of systems most sensitive to a lack of oxygen and nutrients begins with a focus on the neurologic system. Blood pressure definition of hypertension is a systolic blood pressure of less than 90. However, if the patient is hypertensive, a decrease of 40 from baseline is considered severely hypotensive. Jugular veins provide information on volume and pressure in the right side of the heart, as well as capillary refills used to assess the ability of the cardiovascular system to maintain perfusion to the periphery. Assessing fluid responsiveness is an important consideration for managing shock. Consider the use of dynamic indications, including a fluid challenge or passive leg raise. Pulmonary artery catheters are also used less often, given the increase in the less invasive technology. In the early stages of shock, respirations are rapid and deep in the body's effort to counteract metabolic acidosis. Hyperventilation occurs to compensate for acidosis by exhaling carbon dioxide. Use care in interpreting pulse oximetry, as decreased peripheral circulation may result in inaccurate readings. As perfusion decreases, glomerular filtration also decreases, leading to oliguria or urine output of less than 0.5 milligrams per kilogram per hour. The urine will be concentrated when the BUN increases while the serum creatinine remains normal. If decreased perfusion continues, active tubular necrosis will result. Decreased perfusion of the gut results in slowing of intestinal activity. Assessment findings include decreased bowel sounds, nausea, and distension. Of critical importance is damage to the intestinal microvilli, allowing intestinal bacteria to translocate from the gut to other areas, increasing the patient's risk for sepsis. Low perfusion to the liver also results in altered liver enzymes, clotting disorders because the liver is not able to produce those clotting factors, an inability to detoxify patients, and an increased susceptibility to infection. Interaction between inflammation and coagulation also leads to increased clotting and reduced fibrinolysis, resulting in microvascular clotting. This increased consumption of clotting depletes clotting factors, resulting in bleeding. Collectively, this phenomenon is described as consumptive coagulopathy, or disseminated intravascular coagulation that we discussed last semester. Changes to the integumentary system can lead to central cyanosis or peripheral cyanosis. However, this is an unreliable sign. Various laboratory studies can be used to differentiate classifications of shock. A serum lactate level is an overall measure of the state of shock, regardless of the cause. An increased lactate level indicates a decrease in oxygen delivery to the tissue and the shift of anaerobic metabolism. Serum lactate levels are used to monitor the adequacy of resuscitation in shock and the response to treatment. The general management of shock, regardless of type, focuses on identification and the treatment of underlying cause, with the ultimate goal of being the restoration of optimal circulation. A combination of fluid therapy, pharmacotherapy, and mechanical therapies can be implemented to restore circulating volume and perfusion. Efforts also focus on minimizing oxygen consumption and enhancing oxygen delivery to the tissues. The choice of blood or fluid volume and rate of infusion depends on the type of fluid lost and the patient's hemodynamic status, along with coexisting conditions. Volume replacement usually continues until dynamic measures of fluid responsiveness, static trends such as central venous pressure, and/or assessment findings like capillary refill can indicate the patient has achieved volume resuscitation. A CVC may be inserted for large volume replacement or the infusion of high-dose or escalating vasopressors. Fluids often need to be infused at a rapid rate, and infusion pumps are generally limited to a pre-programmed rate of 999 milliliters per hour per infusion. Several additional strategies can be used for the rapid administration of fluids, including infusion of multiple liters concurrently, or the use of a pressure bag, large bore infusion tubing, or a rapid infusion device. Crystalloids are classified by tonicity and balance. In the case of isotonic solutions, they have approximately the same tonicity as plasma. In addition to being isotonic, balanced solutions, such as lactated ringers, have a similar sodium chloride and potassium content to plasma and are felt to have less effect on the acid-base balance. There is evidence to support the administration of a balanced solution, such as LR, as a more appropriate first choice of fluid resuscitation when compared to normal saline. Blood loss should be treated with blood products. If blood is unavailable, consider a restrictive volume therapy with crystalloids to maintain blood pressure. Packed red blood cells work to increase the blood volume and provide more oxygen carrying capabilities. 1 unit of packed red blood cells increases the hematocrit value by about 3% and the hemoglobin value by 1 gram per deciliter. Stored blood is anticoagulated with citrate, which can lead to a chelating of calcium. Monitor any ionized calcium levels in large volume administration. Mind, we want a larger bore IV if possible. A minimum of 20 gauge, though 18 to 20 would be recommended. It is standard for most hospitals. You also keep in mind you want to administer that with a blood filter. Monitor for transfusion reactions, as well as a transfusion administration time that can vary. I've attached below a video below within the LMS that also would reiterate the procedures for administering blood. As with all conditions, oxygenation is going to be a priority, especially in the case of shock. We want to work to both maintain an airway as well as providing oxygenation and considering mechanical ventilation, especially in cases such as sedation or neuromuscular blockade. Let's talk pharmacologic support. Pharmacological supports can be based on the manipulation of cardiac output, determinants like heart rate, preload, afterload, and contractility. And central venous access may be required, especially for the administration as well as hemodynamic monitoring. Again, our priority is going to be cardiac output, maximized by monitoring the preload, especially in the cases of hypovolemic and distributive shock, or afterload, such as distributive shock or cardiogenic shock. Our pharmacological management may also include drugs like sedatives, analgesics, insulin, corticosteroids, antibiotics, low molecular weight heparin to prevent clotting in DVTs, as well as H2 receptor antagonists or protein pump inhibitors to prevent gastric stress ulcers. Let's move on to non-pharmacological support. Body temperature regulation will be key, especially in the case of rapid administration of IV fluids that may reduce the patient's temperature. In the case of hypothermia, this can depress cardiac contractility, impair cardiac output, as well as impairing oxygenation. Consider things like a fluid warmer or providing the patient with warm blankets. For nutritional support, the early administration of enteral nutrition within 48 hours of admission may assist with the maintenance of gut integrity, prevent intestinal permeability, and the reduction of insulin resistance after the initial uncontrolled shock is resolved. Keep in mind, though, that overfeeding patients in the early phase of shock is associated with adverse outcomes. For psychological support, provide information to both the patient and the family, as well as the goals of the care in prioritizing psychological well-being. Among the classifications of shock are hypovolemic shock involving inadequate intravascular blood volume, cardiogenic shock where the heart fails to act as an effective pump, obstructive shock where physical impairment to adequate circulating blood flow, or distributive shock where widespread vasodilation or decreased vascular tone results in a relative hypovolemia. Quick quiz. The nurse admits a 35-year-old patient to the emergency department following a 3-day history of nausea and vomiting. The vital signs assessed by the nurse include a blood pressure of 70/50, a heart rate of 145 beats per minute, a respiratory rate of 36 breaths per minute, and an SpO2 of 92% on room air. The nurse recognizes which classification of shock. Would that be cardiogenic, anaphylactic, obstructive, or hypovolemic? And that answer is going to be D, hypovolemic. That excessive loss of fluid from vomiting, as well as the reduced oral intake, can lead to an overall reduction in intravascular volume and hypovolemic shock. And what other causes could lead to that excessive loss of blood or fluid? It could be everything from vomiting, dehydration, bleeding, anywhere where the body is losing fluid and volume faster than it can replace it. We're going to run that danger of hypovolemic shock where there is not enough fluid, not enough pressure within the vascular space to perfuse the body. That external loss of blood may occur after traumatic injury, surgeries, OB deliveries with collagen alterations, hemophilia, thrombocytopenia, or external plasma losses that have been seen in patients with burn injuries who have significant fluid shifts from the intravascular space to the interstitial space. Appropriate management of hypovolemic shock rests on identifying the underlying cause, such as hemorrhage versus fluid loss, such as excessive GI loss. Once the underlying cause has been determined, it must be eliminated. And the fluid selection is based on the cause of hypovolemia. It may be either blood products, as in the case of hemorrhage, or isotonic crystalloids. The most common cause of cardiogenic shock is extensive left ventricular myocardial infarction, which leads to the inability of the heart to function as an effective pump. Clinical manifestations include left ventricular failure, including S3 heart sounds, crackles, dyssypnea, hypoxemia, or hypotension. It could also include right ventricular failure, such as jugular venous distension, peripheral edema, or hepatomegaly. Pharmacologic agents are used to decrease the preload, decrease afterload, and increase cardiac output without increasing the workload of the heart. Positive inotropic agents can be administered to improve cardiac output. Everything to decrease preload would involve drugs like diuretics, venous vasodilators, while with increasing cardiac output is positive inotropes, arterial vasodilators to decrease afterload, and mechanicals such as a tandem heart or an ECMO. Vasodilators provide additional capacity within the vein, reducing how much volume is returned to the heart. You can administer medications cautiously because they may cause hypotension, further contributing to cellular hypoperfusion. Cardiogenic shock may be managed with mechanical circulatory device. The counter pulsation therapy, concurrently with pharmacological support, can work hand in hand, and this is where the intra-aortic balloon pump therapy would be effective, as it can pick up some of the slack and assist with the work of the heart to perfuse the body. Quick quiz. The nurse is caring for a patient with an intra-aortic balloon pump. Which intervention is most important to include in the patient's plan of care? Would that be turning side to side every 2 hours, assessing peripheral pulses, patting bony prominences, or applying a splint to the affected limb? And that answer is going to be B, assessing peripheral pulses. If the intra-aortic balloon pump migrates, it can compromise circulation to the rest of the periphery. Distributive shock, on the other hand, describes several different types of shock that are characterized by widespread vasodilation. This widespread vasodilation results in an enlargement of the vascular compartment and a relative hypovolemia. The hypovolemia is due to a change in the size of the vascular compartment, rather than the actual loss of fluid volume. This results in a decrease in venous return to the right side of the heart. And what hemodynamic changes would you expect to find in distributive shock? Again, that distributive shock leads to widespread vasodilation and a decreased systemic vascular resistance, which leads to a decreased blood pressure, decreased stroke volume, and decreased cardiac output. Distributive shock. Let's talk neurogenic. This is an interruption of the sympathetic nervous system to impulse transmission, caused by upper spinal cord injuries, spinal anesthesia, nervous system damage, or vasomotor depression. The clinical manifestations associated with neurogenic shock are due to interruption of impulse transmission or blockage of sympathetic nerve outflow, resulting in vasodilation, inhibition of baroreceptor response, and impaired thermoregulation. The clinical manifestations could also include bradycardia with hypotension, warm, flushed, dry skin due to the vasodilation, and hypothermia due to the impaired thermoregulation and loss of heat through the vasodilation. Management of a patient with neurogenic shocks focused on reestablishing hemodynamic stability and correcting the hypotension with volume resuscitation first, then vasopressors if there's no response from the fluid. In the case of anaphylactic or distributive shock, results from the introduction of an antigen to a sensitive individual, initiating an antigen-antibody response. As antigens enter the body, antigens are produced that attach to mast cells and basophils. The mast cells in the lungs, around blood vessels, and connective tissue, and in the uterus release vasoactive mediators in response to exposure to an antigen. The clinical presentation of anaphylactic shock consists of upper and lower airway angioedema, cardiovascular, and integumentary symptoms. The angioedema symptoms consist of swelling of the lips, eyes, tongue, hands, feet, and even genitalia. Tachycardia and hypotension are the primary cardiovascular symptoms, with cutaneous reactions that stimulate itching and pain that lead to pruritus and urticaria. Management of an anaphylactic reaction involves removal of the offending agent first and foremost, as well as stabilization of the patient's airway. The drug of choice for treating anaphylactic reactions is epinephrine, an adrenergic agent that promotes bronchodilation and vasoconstriction. Histamine blocking agents such as ranitidine and Benadryl are appropriate medications but are used as secondary agents, while corticosteroids may be used to reduce the inflammation. On the other hand, septic shock is a part of a continuum that begins with the invasion of the host by a microorganism. Following the invasion, an inflammatory response is initiated. The situations that increase the risk of sepsis fall into two categories: those that cause immunosuppression and those that cause bacteremia. The clinical manifestations associated with septic shock are directly related to widespread inflammation and enhanced coagulopathy. Priority management strategies include preventing the development of the continuum of sepsis, timely identification of causative organisms, and the initiation of culture-driven antibiotic therapy can improve survival of patients with sepsis or septic shock. Often blood cultures and other suspicious sources before initiation of antibiotics, but do not delay that initial administration of antibiotics by more than 45 minutes. We want to treat this patient as quickly as possible. Initiate the sepsis bundle within the first hour of sepsis recognition. The sepsis bundle includes IV fluid resuscitation if the mean arterial pressure is less than 65 or a lactate level is above 4. Isotonic crystalloid solutions are infused for fluid resuscitation, with some evidence suggesting that balanced solutions like a lactated Ringer's are preferred. You can also consider administering vasopressors if hypoperfusion persists despite aggressive fluid resuscitation. Transfusion of packed red blood cells is recommended when hemoglobin is less than 7. Obstructive shock occurs when there's an impairment of effective circulatory blood flow. Common causes include cardiac tamponade, tension pneumothorax, constrictive pericarditis, or compression of one of the great veins. Common clinical manifestations in obstructive shock include chest pain, dyspnea, jugular venous distension, and hypoxia. Pulmonary embolism treatment is dependent on the severity of the right heart strain and hemodynamic stability. But regardless, we want to focus on treating the underlying cause. Quick quiz. The nurse is caring for a patient with severe sepsis. Blood cultures are pending and antibiotics are infusing. Vital signs assessed by the nurse include a blood pressure of 88/60, a heart rate of 145, respirations of 28, a temperature of 101 degrees Fahrenheit. The lactate is 4.2 and the SpO2 of 94% on 3 liters nasal cannula. Which physician order should the nurse initiate first? Would that be bedside glucose every 4 hours? Tylenol 650 milligrams PRN for a temperature over 101? Begin infusing norepinephrine? Or the rapid administration of 30 milliliters per kilogram of lactated Ringer's? And that answer is going to be D, administering the lactated Ringer's. The rapid administration of these fluids for hypotension is part of the sepsis bundle. These should take precedence over the initiation of vasopressors, and vasopressors should only be administered if the patient remains hypotensive during or after the fluid resuscitation. Moving on to multiple organ dysfunction syndrome, or MODS. This is a progressive dysfunction of 2 or more organ systems, with the most common cause being septic shock. It can occur after any severe injury or illness, though, with mortality rates including 54% with failure of 2 or more organ systems and 100% in those with 5 or more organ system failures. The maldistribution of blood flow to various organs can The clinical manifestations associated with MODS are a direct result of the damage caused by the inflammatory mediators, also the tissue hypoxia and hypermetabolism. Damage to organs occurs sequentially, with the pulmonary system being the first affected. This would result in things like tachypnea and hypoxemia, moving on to petechia, bleeding, petechiae, bleeding, jaundice, abdominal distension, oliguria to anuria, tachycardia, hypotension, and altered level of consciousness. The management of MODS centers on preventative and supportive therapies, including the prevention, early recognition, and support. Management include controlling the infection and inflammation, providing adequate tissue oxygenation, restoring intravascular volume, and supporting each organ function. Shock is a life-threatening emergency, including the early recognition and management to prevent progression to multiple organ dysfunction, organ failure, and death. The clinical presentation varies based on type and the stage of shock. The four classifications of shock, again, hypovolemic shock is the inadequate intravascular blood volume. For cardiogenic shock, the heart fails to act as an effective pump. Obstructive shock, there is a physical impairment that's impeding the circulating blood flow. And for distributive, that's that widespread vasodilation, including forms like neurogenic, anaphylactic, and septic. But anyway, that's all we got for this chapter. I'll see you in the next slides.